Hello, everyone. My name is Tyler Bell. I'm a postdoctoral scholar at the University of California in San Diego in the Department of Psychiatry. And today I would like to discuss how persistent pain relates to the risk of mild cognitive impairment in a group of older men. I'd like to first acknowledge that the land that I've been able to do research on is the original home of the Kumai people who have nourished, healed, and protected this land for millennia. Pain is defined as the unpleasant experience of actual or potential tissue damage, and persistent pain specifically is defined as pain which lasts 3 or more months, and this affects 20% of older adults, or about 1 in 5. Persistent pain is linked to many barriers of successful aging or aging well. Predominantly, this involves physical barriers. Persistent pain is the leading cause of functional limitations and disability around the world, especially in older adults. Persistent pain is also linked to emotional barriers, including greater rates of depressive symptoms and anxiety symptoms as an individual ages. And recently, what we'll be focusing on is the association with cognitive barriers, as recent studies have linked persistent pain to cognitive decline and dementia risks, which are greater than normal. As an example, Whitlock et al. Used data from the Health and Retirement Study to look at performance and cognition in individuals with persistent pain and without persistent pain. And as shown in this first graph in orange, people with persistent pain had lower memory scores over time compared to people without pain, as shown in blue. In this other graph, you can see that the actual probability of dementia was greater in people with persistent pain, shown in orange, compared to people with no persistent pain, shown in blue. For this project, I really wanted to provide data to really get to the nuances of these associations that are useful for researchers. Specifically, previous studies have only been able to look at memory performance, but how does persistent pain relate to other cognitive domains? I also wanted to look at persistent pain's relationship with MCI specifically rather than dementia risk, as MCI is a key period for intervention purposes, as MCI may be able to be intervene to reduce the risk of dementia. Meanwhile, dementia is so far irreversible. Third, I wanted to look at how the way you measure pain matters. So you can measure pain either through intensity, so how much you have pain, versus how it affects daily activities, which is called pain interference. And you can also classify people who have persistent pain by whether or not that pain is mild over time or moderate to severe over time. So I really wanted to break out what measure really relates to the cognitive decline and MCI risk, which could be useful knowledge for clinicians and researchers. The data was derived from the Vietnam era twin study of aging, which is a 3-wave study of older twins that originally signed up for the Vietnam era twin registry back in the 1960s. And these individuals were average age 56 when they participated in this specific study, and then followed up at average ages 62 and 68, approximately 5-year intervals over time. And currently we are undergoing our 4th wave of collection where individuals are obviously much older. Overall, about 1,000 people participated in the waves. And you'll see that we kind of reduce the data to get rid of individuals that may have conditions or MCI unrelated to Alzheimer's disease, which include having schizophrenia, seizure, stroke, et cetera, as well as having brain abnormalities, because our study also included scanning that would indicate that they have some kind of pathology unrelated to Alzheimer's disease. Our measures of pain came from the SF-36, which is a common measure of health and well-being across aging data sets. Pain intensity was measured by how much pain severity have you had during the past 4 weeks. You can report this from none to very severe, which is on a 1 to 6 scale. And pain interference was asked by how much did your pain interfere with your normal work, which can include work outside the home and housework. And you rate this from none at all, 1, to extremely 5. And overall, in general, we define persistent pain similar to the Whitlock et al. Study by having pain that persists over 2 or more waves. But we use the different response ranges to classify either mild to moderate to severe levels of persistent pain intensity or persistent pain interference, as you can see here through the criteria. Our cognitive measures were standard neuropsych measures, which really captured a lot of different domains, including episodic memory, executive function, attention and working memory, verbal ability and language ability, visual spatial ability, and processing speed. All these performance data was really used to classify MCI using the Jack-Bondi criteria. This criteria has been used and shown to be more specific for dementia risks than other criteria that are used, and it defines individuals having MCI as those who perform 1.5 standard deviations below the mean and 2 or more tests within a cognitive domain. It further breaks down people who have amnestic MCI subtype, which includes an impairment in the memory test specifically. This phenotype is important as this has the highest risk of dementia specific to Alzheimer's disease. But you can also classify people as having non-amnestic MCI, which involves impairments in non-memory tests only. And this is also related to Alzheimer's disease, but also linked to a lot of other mixed pathologies and vascular related dementias. We adjusted for practice effects over time, as well as longstanding cognitive differences from average age 20, when individuals completed a cognitive testing for their entrance into the armed forces. For cognitive decline, we use factor scores that we previously validated in the literature, which include scores for episodic memory, executive function, and processing speed. These are important outcomes as they are highly linked to pain in previous studies using various age samples and also recent cross-sectional work in older adults with pain. And we also looked at other factor scores for fluency, visual spatial ability, and sub-factors for working memory and semantic fluency, which I won't go into detail, but capture a lot of other cognitive domains that we can look at. Looking at demographics, you can see that at baseline we have 1,000 people. It goes down to around 700 at the third wave. And these individuals obviously get older over time. They have somewhat more than a high school education. But what's important to note is that they are predominantly non-Hispanic white. And this should be acknowledged as we proceed with the generalizability of the findings that I'll show you. And I also want to note that the number of opioid used medications is very low. And when you split it up by sample, of course, it's higher in the people with persistent pain, of course, but it's still relatively low at about 20%. So opioid medications are controlled for in this study, but as you can see in community dwelling older adults, they're not extremely common. Looking at the frequency of our key variables, newly occurring cases of MCI, so cases of MCI that are incident and used in our analyses, kind of occur at about a rate of 4% at wave 2 and wave 3 as individuals get older. And it seems to kind of break down into about an equal number of people that have amnestic or non-amnestic MCI. Persistent pain intensity was about 20% if it was mild or moderate to severe. Persistent pain interference broke down and was much lower to about 10% for the mild cases and about 3 to 4% for the moderate to severe cases. For our analyses, we looked at cognitive decline using age-based linear mixed models of pain predicting cognitive function over time. We adjusted for age, opiate use, the general cognitive ability measure, as well as health conditions, which involve major conditions such as heart disease and diabetes, and also for depressive symptoms using the Center of Epidemiological Studies depression scale. We look at the risk of MCI by using Cox proportional hazard models predicting time to MCI based on age. We also control for opioid use, health conditions, and depressive symptoms. Looking at persistent pain intensity, we see that there is results isolated to certain cognitive domains, specifically in the moderate to severe range of persistent pain intensity. It occurs mostly in executive function and working memory. So these individuals have more declines in executive function and specifically working memory, which the effect is stronger for the subfactor. We also see a trend level effect that these individuals have lower episodic memory over time, though not reaching to the level of significance. For persistent pain interference, we see results that are similar in terms of the pattern of effects, even though the effects are stronger. We see that these individuals have lower executive functioning and working memory over time. They have moderate to severe persistent pain interference, and there's not a trend effect for episodic memory in this case. Looking at executive function over time, you can see that individuals that had moderate to severe pain, they had lower executive function over time compared to people with no persistent pain intensity. You can also see these for the individuals that have persistent pain interference that are moderately severe. Looking at MCI risk, you can see that individuals that had persistent pain, the only associations that showed up, as shown in gold here, were with the outcome of non-amnestic MCI, not amnestic MCI. And you can also see that this really breaks down to individuals that have moderate to severe, either persistent pain intensity or persistent pain interference. And you also see that the hazards risk is about 75% for individuals that have moderate severe pain intensity and about double that for individuals that have moderate severe persistent pain interference. You can see this graphically here. So you can see that the risk of having non-amnestic MCI over time goes up with age, and this is much higher in individuals with moderate severe persistent pain intensity compared to those with no pain. And you can see that the relationship is even starker here, or the differences are more stark in looking at pain interference. So overall, pain is related to executive function decline and also the risk of non-amnestic MCI, which likely involves that executive function decline. This aligns with previous meta-analyses of case control studies. Berryman et al. In 2014 found that people that have persistent pain had worse executive function consistently across studies. My study previously has shown that similar findings in widespread pain across ages. But what was unexpected was no association with memory decline or amnestic MCI. In my previous work, I'd shown that individuals with widespread pain had worse episodic memory, whether it was measured short-term or long-term recall. And in the Whitlock et al. Study, we saw that persistent pain related to memory decline in older adults. And the possible reasons for the discrepancy could be that our sample focused on community-dwelling older adults, whereas my previous study focused on clinical cases. And also with the Whitlock study, they had a lot more power. They had more waves of assessment and about triple the sample size. And you did see a trend for pain intensity in our study with episodic memory, as I showed in blue in that one table. I knew this was going to be complicated to break down into multiple pain phenotypes, but it seemed worthwhile because what we saw was that moderate to severe persistent pain was more related to cognitive measures, while mild persistent pain was not. This builds on a lot of previous studies that are out there that haven't received a ton of attention, but Griswold et al. Found that in healthy controls, it took severe levels of pain to really disrupt executive function in adults. In the English longitudinal study of aging, they found that older adults only with severe pain faced memory decline. So, although we didn't find a result with memory decline, this could be relevant to our results. And functionally, there's probably some brain reason for this, as studies have shown that brain activity disruptions related to pain only occur observably at moderate to severe levels, although that may have changed in the decades of imaging research. Pain interference also had a higher association with cognitive measures in pain intensity, which also shows us, that asking about chores and disruptions in daily activities may be more important than asking people to rank intensity levels. Van der Leeuw also found this association with cognitive performance in older adults that, more broadly connected to cognition than pain intensity. And Azadi et al. Found that pain interference was more related to dementia, but not pain intensity. So perhaps pain interference will more capture people that have cognitive decline that do result in dementia cases. And it's also relevant because the NIH has begun focusing on people with persistent pain interference, which they label as high impact pain. So this group may be important for us to focus on as we study individuals at risk with pain for dementia. For my research implications, I really like to acknowledge that pain needs to be assessed in older adults. A majority go unscreened for pain. 4 out of 10 individuals do not get pain assessments, even though the primary reason for going to a medical office for most individuals is because they have pain. There's some myths that may be involved. So patients and physicians may think that pain is normal as we age. It is not. There's no evidence for that whatsoever. There's also a second myth that older adults feel less pain as they cognitively decline. So there's structures in the brain that are responsible for pain perception. We think that one of the benefits is that you stop feeling pain as it deteriorates, but that is not true. Pain is a very important survival mechanism. It is important that we perceive it. And so it's likely to stay for a very long time. And individuals that have Alzheimer's disease still have pain. Only thing that changes is the communication, how people are able to report on their pain. And there's a lot of behavioral measures and nonverbal measures that can be used to measure pain, but we cannot skip this assessment process. Pain also needs to be managed. It's not enough to just say that someone has pain. You got to do something about it. We have a duty to do that for our patients and clients. Individuals that have pain, 21% do not get treated for pain, even when they get screened. So that even in the lucky people that do get screened, the 1/5 of them go untreated. And that's not okay. And I just want to acknowledge that this is more pronounced for people of color who are commonly underscreened and treated for pain across the lifespan. And this has to be acknowledged as a result of structural racism, as well as race myths that have been in medical science for a long time. I'd like to acknowledge the National Institutes of Health and the National Institutes on Aging for their support for the Vietnam era Twin Study of Aging, the participants who gave their time and their commitment to the study for many, many years, as well as my mentors, William Kremen, Carol Franz, and Jeremy Ellman, who helped guide me and train me on this project. Thank you so much.